Greetings to all. I, dear Saama from Shaha University, on behalf of my team, here to present a paper on deep learning tool for COVID-19 pneumonia classification under paper ID 6411. As we all know about the COVID-19 virus, the same can affect your lungs, causing pneumonia, where the virus infects the airways, and to fight off this infection, the immune system causes inflammation. While most of the people aging under 60 eventually survive pneumonia with safety measures, the mortality rate is 31% for those above 60. The proposed method is tested on a standard PC of Windows 10, 64-byte, any CPU, GPU, and Google Colab notebook. Deep learning can evaluate health records quickly and reliably, including structured and unstructured data such as lab test results, diagnosis, and so on. CNN is one such popular method because of its capacity to analyze complex data. The principal uses of CNN are often image processing, where it has made a significant breakthrough when Google used it to diagnose cancer at an accuracy of 89%, while human pathologists could only attain an accuracy of 70%. As a result, a model is built based on this approach to serve the study. We have taken this research paper under consideration to prove the efficiency of our investigation. In the study from 2019, the authors have a similar approach to that of ours. While they have trained their model on 3,722 X-ray images of anterior, posterior chests of retrospective pediatric patients between 1 to 5 years of age, producing validation accuracy of approximately 94% with a minimal training loss of 0.1835. This section outlines a comprehensive model of the deep learning tool for COVID-19 pneumonia classification. The convolutional neural network model was built and trained using Keras, an open source deep learning framework with TensorFlow API. The architecture consists of three stages. Firstly, the dataset. The original dataset of 2,295 images is divided into two main folders, namely training and testing, and two subfolders, namely COVID-19 positive and negative chest X-ray images, out of which 712 are positive and 1,583 are negative. Next, we have the pre-processing and augmentation stage. We used a number of data augmentation methods to ensure the growth and quality of the data sets. They assisted in reducing overfitting issues and improving our model's overall performance while training. The combinations implemented for picture augmentation are described in the table. So, we'll start by rescaling the data by a factor of 1 by 255. This helps during the normalization. The training set is then separated into 20% of the validation set, and hence the validation underscore split constraint is used to do this. Finally, we have the training stage. Upon insertion of the images into the system, the convolution is used to extract the image features. Before ReLU, the Conv2D block receives input and then performs max pooling and dropout regularization. The convolution is repeated in the last layer to flatten the data into a 1D array for the connecting layer. This time we're going to add filters. The final stage is to apply a dense opaque layer with sigmoid activation. As a result, we send the image to Con2D for convolutions or feature extraction before adding mask to the pixels. These data are received by our highly interconnected artificial neural network. This is an illustration of the proposed model framework presented in the form of the figure. As technology influences practically every part of our lives, we developed this method to identify and classify pneumonia for COVID-19. This method begins by reducing the size of the chest X-ray images to a fraction of their original size. A CNN framework is then used to enhance the photos by extracting and classifying image characteristics. Our model's validation accuracy was marginally higher when compared to other approaches. The graphs represent the loss and accuracy of training and validation during the model training. Here we can see that the validation accuracy was close to 98%, while the training loss was only 0.0677%. Additionally, the validation value was 0.0372%. The accuracy of our test was decent, coming in at about 97%. Moreover, as seen in the graphs, the test loss is just about 0.7071% for 30 epochs. Our proposed method has the potential to serve as a useful tool in the healthcare sector for the classification of positive and negative COVID-19. The model is built up from the scratch, unlike other models that are based on transfer learning. In the future, we plan to extend the model's capabilities by enhancing chest X-ray images of retinal image analysis, skin cancer detection, and more that could potentially be applied to other medical areas as well. Thank you for your cooperation. We are ready to clear doubts regarding the proposed approach, if any.